that the disease is a disease with two victims. So you have the patient and the caregiver. It's not a one-person disease. It's really a family type of disease. Many times you see a patient who is doing not bad, but the family is not doing well, and they actually can deteriorate the patient cognition. What we do in the office, we take care of the whole array of problems that the patient and the family is going to have. And that's starting from medication management, polypharmacy, stopping medication that can cause more problem with memory, like medication with anticholinergic type of drug. We do have investigational type of medication. We have all the support that we can give to the family. Counseling, family support group, refer to type of senior care where they have a lot of brain stimulation and playing with patient with memory that actually is as effective as like 50% of the medication. So it's just as effective like giving medication. It's just giving medication is not always enough. The earlier you detect the disease, the better is the outcome of the treatment. There is no doubt. The target is to work and help the primary care, to be a consultant to them, and with that we can help the primary care to do the neurobehavior, testing their cognition, predicting the rate of deterioration, and start with early treatment. And the early treatment can be not always with medication, even with counseling is part of the treatment. We are just a consult on this case, so we do help the physician who is the primary care to manage those type of patients. And usually what we have good satisfaction from those physicians who refer patients to us.
We'd really work as a team with the primary care physician. I think our specialty comes into play as patients begin to deteriorate. In the early stages of the disease, they're very easy to manage, and they're maintained on their cognitive medication. But as the cognitive medication ends up wearing out their cycle and new drugs need to be added and behavioral changes start to interfere with the patient's day-to-day lives, they become very complicated to manage. And it's not only managing just the patient, it's managing the caregiver and trying to teach them and educate them in how to work with their medical team as the patient progresses. Usually a primary care physician's office is very busy and handling a lot of massive phone calls from caregivers day in and day out can be burdensome on the primary care team's staff, where we would help in that way since we do have people who can take those calls from the caregivers and teach them and do the patient and caregiver education that's required to help manage the patient. What we do if a patient is on a study, we keep their primary care physicians very well informed. There's a copy of the informed consent that's provided to the primary care physician. Many times I also speak to the PCPs directly on the phone, educate them in the trial and what they might need to look for. It would be very important for them to also keep communication with us because they may see the patient and make changes in their medications or treat some adverse events which would be important for us to be aware of. Dr. Shua-haim has been taking care of Alzheimer's disease patients now for close to 20 years. He's done all the research in every single drug that is on the market. So his clinical experience and the expertise in understanding the pharmacokinetics, the pharmacodynamics associated with the drugs that are used far surpasses what a primary care physician may know when they're dealing with a much broader population. The caregiver requires hours of support and education. Our team has the ability to offer that education. We run symposiums free of charge for caregivers. We also run a support group, which is one of the largest in New Jersey, that's supported by the Alzheimer's Association. So it's those kind of connections and those kind of support networks that we have in place that the primary care physician doesn't have, that we can help to alleviate all of the time that is spent in educating and supporting the caregiver, of which is not reimbursed through Medicare.